This is Megaphone for Medvale Media. I'm Dave Self. This is where we hand the megaphone to healthcare leaders to share their thoughts, their perspectives, and as you know by now, the occasional rant about the increasingly dynamic world of healthcare. And today it is a privilege to welcome Kevin Lawhorn, one of the newest members of Medvale and Senior Vice President of Growth for Myriddian. Kevin, welcome to Megaphone.
Thank you so much for having me, Dave. It's an absolute pleasure.
Well, let's kick this off with your background, where you're from, and the path that's led you to your current role at Myriddian.
Yeah, happily. So I'm born in California, Northern California, and then my family moved to Boise, Idaho when I was very young. But I grew up in Boise, Idaho. I am very biased, but I think it's the absolute best place. I mean, we're an outdoors family. Grew up where you're 20 minutes away from the mountains or 20 minutes away from the river or a lake. It's just the best place. And to have a central community trail, that runs through the river or by the river every day, it's just the best. Always knew I'd be in healthcare. I had a uncle who's an orthopedic surgeon, and him and I were the black sheep of the family, the studious nerds of the family, where we gravitated towards games like Scrabble and crossword puzzles, where we knew that was going to be our, I've always knew it's like, hey, be like Uncle Jeff. That's fine. And so had the plan was to go pre-med, take prereqs at Boise State, go pre-med. That lasted, and then go to UW. But that was the plan. That lasted about 6 months, first semester. And then parents told me it's on your own. So I got a job. I was a certified nursing assistant that I had accomplished in high school.
Really?
And so that was so I was a CNA in high school. I was working at the local SNFs at the skilled nursing facilities in Boise as my junior year and senior year nighttime job. I didn't have to do any peri care, but there was a couple times where it came close. But I had to. We were doing like just general level intubation and a nighttime shift, obviously. So as a post dinner or even like a dinner serving, where we had to kind of manage the patients there, and it was great. But I needed like a real job outside just nighttime when I realized I had to pay for college potentially on my own, and that's where I applied to a company called Norco, which is a large medical supply company in Boise, at right at the turn of 19, and loved it. Got into the executive leadership training there. Those guys, that whole executive leadership team I wouldn't be who I am without them. They're the best. And they got me to kind of go down this path of what was business administration. And then took all but up until 24 credits at Boise State, and I did not finish. But it led to 7.5 years of just like going towards executive leadership, managing certain areas. I ran the McCall area, which is a large mountain region in Idaho. Led that for about a year. I managed that myself in a small team. And then I became really bullish on healthcare technology at that time, wanting to differentiate myself from the current corporate ladder, knowing that it wasn't really an IT integrated company. And so I wanted to fully invest into that and use that as my differentiator. And just had some different misalignments throughout the company structure and plan. And so I left and then started consulting for the large medical supply entities like McKesson Pharmaceutical Division and Medical Supply Division, really getting into like the healthcare supply chain and logistics at health systems. And I did that. I had secured contracts right out the gate with when I left Norco with Medline, McKesson, and Cardinal, which Independence Medical, which became Cardinal.
Wow.
The small little company I had, I was just a plant where they would put me into different health systems or medical supply companies or home health and hospices, and we'd start to revamp, what supplies are used at this point in time, and really start to look at the continuum of the patient journey and how that led into the right product at the right time. And that started to really was a fascinating stint. And then did that. It worked out okay. It wasn't bad. And then it led to wanting to go more in the tech route. My wife and I started a company in about 2016, a different company in 2016 that was really getting into digital mechanisms to healthcare. So like how prescriptions are originated, how points of like the point of origin when it comes to like medical supplies and that specific patient provider encounter, and how we could really start to glean from that at that moment. And so we developed a script mechanism that had integrations with Epic and McKesson and Point Click Care. We were able to grow quite well until we ran into this event called COVID, and it was the best thing and the worst thing for the company. And I think that what we learned through that was we had a mild soft landing as far as the company closure, but it led to the position I have now. I met them during my Myriddian team, and their founder and their board. I met them during COVID while we had our company, and the whole time they were just trying to convince me to leave. Do this for the we do supply chain logistics, and we do disease surveillance and healthcare integrations and IT consulting for the federal government. Like, come on, come join us. And so the appetite for like the acceptance of like, okay, this company may not be the long haul like I thought it was, led to Myriddian. And now, yeah, so I oversee the all of our different verticals from a commercial side, state side, and federal side. And so I'm the lucky one that leads delivery, is what that's called,
Okay.
where I go in and we build the plan, we solution architect around the existing environments, and then I go into the government level and sit down with the secretaries of health, or sit down with the 2-star, 4-star generals, or rear admirals for the military health system or the VA. And we really build like deep constructual plans and mutual methodologies to how we're going to build these solutions. And right now we're on some very fun projects where we are leading some of the efforts around military health system and transitioning to healthcare delivery, with some of our large corporate partners. We've done, part of the EHR implementation to the Oracle Cerner product at VA. And then we're also doing some disease surveillance projects with CDC, working with companies like Palantir, Microsoft, and then also doing some pseudo consulting on we haven't monetized it yet. We're doing some pseudo consulting as we package up different offerings for Social Security benefit determinations and leveraging EHR integrations to quicken that process for individuals, which is a really exciting project. Yeah, that's just what we do now. So now I feel like I'm thriving. So yeah.
So, so like most members of Medvale, you as a Medvalista are a slacker.
Yeah,
Clearly
100%.
from your career track, you just have been
Yeah.
slack. No, that's truly a fascinating phenomena. There are very few people that we have had on Megaphone that have this clear, bright line. There are a couple that have a clear, bright line from where they started and what they had in their mind to do to where they are today. And it's just this crazy trail, and it's not luck and it's not fortune. There's a lot of hard work that goes into it. And I
Yeah.
think it's the willingness to take a risk. So thanks
Yeah.
for sharing that with us. Yeah, Kevin, I believe Myriddian has 3 key markets. Is that right? Government, commercial, and healthcare. Is that correct?
Government, commercial, and state. Healthcare is the core
Okay.
pillar, the continuity between the 3. So we do some aspect of healthcare in all 3 verticals. Yeah.
Got it. So why don't you unpack what Myriddian you started to do that. Unpack what Myriddian can do and why clients come to you.
Yeah. I mean, that's a great question. So, first and foremost, we're physician founded. So, the CEO and founder, she's an autoimmune pathologist and she's entrepreneur by nature. So, she actually started the company. The first contract Myriddian got was doing Epic implementation for Johns Hopkins. That was the first contract that Myriddian got as far as its pathway to pursuing the success it is today. But so she did that about 2010, and then got into the federal contracting side through that kind of Johns Hopkins lens of consulting, realizing that EHR implementation was going to be the future for the federal government and federal healthcare systems. That's what was the immediate crosswalk in the federal space. And so we had some acquisitions, and then in the commercial side, we still do the core Epic implementation and training. A lot of nurse triage, care continuity training that we do at the health system level. We only have about 20 different health system clients. Go ahead.
Around Epic or just broadly?
Both.
Okay.
No, both. Yeah, both. Yeah, primarily it's Epic and Oracle Cerner. Is what we center around. There's some answer ones that we've tried. They've tried in the past. And and it just seemed like a rabbit hole. And that was obviously the differentiation between like, oh, is our ideal client health system, critical access, or like FQHC or primary care? They didn't have the growth leads around at the time were not healthcare focused. And so it was definitely more broad, like just grow to grow type of thing. And so one of the attractions that the CEO had with myself was that it was the ability. I had a history of crosswalking health system navigation, like contractual or contracting or doing business with a health system is much different than a standalone critical access, standalone FQHC, and let alone primary care or anything else in the post-acute space. And so that's where it's a different sales process. And so really, when I came on, it was quite frankly gutting that rabbit hole. And so what that led to was it's very keenly focused on healthcare is our DNA. I mean, we fully embody the truly the health and IT is no longer separate. It's the exact same thing. You can no longer conduct healthcare without an IT capacity. I mean, everything is
So true.
integrated. The IoT. I mean, there's a system security. Uh, I mean, information security you have to look at. It's how the connectivity between the health system. I mean, we have a contract with Verizon where we're on the Verizon health side doing training for Verizon of how they implement, broadband server capabilities across their healthcare clients. And that's one of the cool commercial works that we have. We also in the commercial space partner with we do policy and data analysis. And what we did there was that was an acquisition I was able to be part of where we bought a company that ingested all state and federal legislative bill content. And then what we do is like literally everything. We have like these spiders that grow out to every single state site and ingest that all the bills that come out in different legislative sessions. And then we package that up. We structure that unstructured data. So we scan all the PDFs, we scan the notes, we scan the bills, we take unstructured, normalize it, and synthesize it into structured data, and then we package that up to our commercial clients, Walters Clore, Bloomberg, Politico, and we lead their tool. Our data fuels their tools, and that part is fun from a healthcare side because there's a lot in medical record review it's the same exact process, and that's actually because we're so strong in medical record review for our disease surveillance side. That's what got us into knowing it was the same process for this side. And now the crosswalk of what is healthcare policy to healthcare decision making and point of care has been a fascinating thing to watch that evolve from a policy point of origin and telehealth capabilities and how that translates into the actual care setting. So
So
that's fun.
what you just described there at the end around being with Walters Clore and the others, the old saying, with all due respect to NVIDIA, they used to say the intel inside. So that effectively for those organizations, if you're fueling their tools, you are the content of
Yeah.
what they're able to provide.
Yeah. Well said. I
Fascinating.
mean, and we are. Yeah.
Fascinating.
It's a fun project. That one, I'm actually like, it's probably one of my more bullish verticals that we have is the policy side, just because, I mean, medical record review is, I mean, and the way the healthcare financials are changing at the health system level, like there's a lot from a policy side. Like, do you need the full medical record to make a decision making, or should the full record review delay, yield or limit your financial, transaction and recuperation from the financial mechanisms? Like, should that happen? And that's where we're still learning as we speak. I mean, we're bringing on some experts on the team that we brought on, and we're trying to figure that out.
You're deeply engaged with the federal government, I know, on a number of
Yeah.
different fronts. So let's open the big black box for a minute. Hear your thoughts about where government agencies are taking healthcare. What's the gospel according to Kevin related to that topic?
Yeah, that's to give the benefit of the conversation, federal revenue is only about 40% of our revenue. It's about 37% of our revenue. It's 99.9% of the energy and focus, just so we're all clear. And so it is, I mean, the just the tedious nature of getting on site, approval, security access, all the things, and meeting minutes, etc. It's 99.9% of the focus and energy sometimes. What I will say is, having been in Myriddian through 2 administrations now, and definitely through the specific transition of very diverse and polarizing administrations, is it does seem like there is an aperture and a clear focus for this administration to unlock a lot of this like bureaucratic red tape when it comes to healthcare. I think
What
one of
what
the
does
key
what does that mean?
Um, so unlocking bureaucratic red tape, meaning like care access and health equity. So a lot of times what was underlying impact that we've seen, that the federal government, at least I shouldn't say we as Myriddian, but the federal government has seen, is that there was an almost like unintentional consequences when it came to health equity guidelines that were having this an effect that they did not account for, where there was prioritization of funding mechanisms to federally qualified health centers or critical access centers or Medicaid populations as far as the state percentage of grants that or the subsidies they receive for the Medicaid populations that pertain to health equity that they did not know that was really going on. And so it was basically, we need to prioritize health equity or health access. And that was also limiting even some major areas from receiving care as well. And that's part where they've intentionally been removing that, in the sake of like, we need to see every patient and we need to fund for all events, not just these, populations that were more underserved. And that's the part that's interesting. I don't know if there's going to be unintended consequences even in that. And there very well could be. I mean, healthcare delivery is complex, and when it's governed by people in DC that haven't been to an FQHC and don't know that the paint on the walls is still from the 70s, that mute brown or beige brown that we all know of, it's very challenging to hope for. But I will say the willingness to figure it out and go on tours, they're trying to do it, and they're trying to look at it as a way to repurpose funds that are in that waste and abuse space, the fraud, waste and abuse space, but it's now really centralizing in on the waste and abuse, and trying to repurpose that into more proactive programs. So then all populations are preserved and served equally. That seems to be the biggest narrative and focus of the HHS side for sure. Which is the part that's pretty interesting, working closely with that side.
You've touched on something that, depending on who you speak with in healthcare, there are divergent opinions, to put it mildly, when we talk about health equity. The
So
definition of health equity from the current federal level and down, as you point out, to the FQHCs, the people truly that are on the ground, the tip of the spear in delivering healthcare to very diverse populations.
yeah,
And the narrative that we hear from many people who either operate FQHCs or are the organizations that knit them together on a statewide or regional basis is that waste and abuse is not their problem.
correct.
It is the level of funding available or the reimbursement for services rendered.
Well said.
Do you see these things, or can you
So
comment on
totally.
these things being in opposition to one another? Or is there a path that you see these things diverging and coming together so that the FQHC world can be better served?
I think they're coming to be better served, quite frankly. Because I mean, yeah, the anybody who's been in healthcare long enough knows that the waste and abuse and the fraud, waste and abuse is so subjective. It is,
Really?
and that's where, I mean, I'm a very outspoken advocate for, you cannot penalize providers or demonize providers' efforts when the margins are so low and hard to obtain, because that is not necessarily waste and abuse or let alone fraud on their part. It's absolutely not. But there are errors that can occur around duplicative billing or duplicative patient seeing and stuff like that, where it's like, this is a natural, because the system is complex. Care navigation is complex. And that's the part where I will say it is starting to diverge, where they are repurposing,
Mhm.
reducing the efforts of what they're putting into and consolidating the efforts what they're putting into fraud, waste, and abuse, where they're no longer just issuing it as a contract. And for example, the fraud, waste, and abuse market, as far as Medicare funds, so contracting with CMS is about a $200 million a year industry, for that CMS pays fraud, waste, and abuse entities to contract them and go seek out and find the fraud or the waste and abuse. The challenge that, though, is that that's a lot of money that could be repurposed, because the thing that when we're allowed to be in the room and talk about that specific thing, the advocacy we bring to the table is that you can say you're finding and looking for it all day long, but to actually find out what is recoupable, the percentages of what they put in, what they invest to find, and what they actually recoup are dramatically different. And so, if the whole point was what they, and the benefit of who they've appointed in the new administration, um around some of the Doge team and how they were working with Center for Program Integrity at CMS and their efforts, and more importantly, how Kim Brandt, the leader of CPI for a long time, which was Center for Program Integrity, is now the chief operating officer for CMS. She comes with a wealth of knowledge to know that she knows that exact same thing. We've invested a lot to go look for it, but we haven't necessarily got a return on our investment of what we recouped and been able to churn in policy and repurpose. And so now they're starting to look at what they've limited contractually from year over year standpoints. They're now repurposing those efforts to focus on better rates, better margins, and increased billables for providers, which is where you're kind of starting to see, okay, they're willing to not rely so much on the vendor community who contracts CMS, but spread that out to the provider community, which they're relying upon. And that's the part I will say I am optimistic to see where it's going.
Well, if they are successful, it would be a big win for the people at the FQHCs and would
I agree.
have it should have a positive cascading effect through the system
I would hope so.
to other nonprofit health systems, hospitals, county-run hospitals, et cetera. Because if the FQHCs are operating at the top of their license and are funded appropriately, that should take some of the pressure off the unreimbursed care, charity care, et cetera, other places. I would think. So you are deeply involved, as we've established, with various federal agencies. Um, Earlier this week, CMS stated that for 2027, the reimbursement for Medicare is going to be at a pretty flat level, immediately causing, uh, I'm sure, a number of C-suites and investors to go, "Oh no!" I think United Healthcare stock at the next
Oh
day
yeah,
18%, and others were just
yeah, just straight
he-
down.
heading down. So, what is your take on the action by CMS for 2027? Who wins? Who loses?
Well, to give context in that, I mean, their MO is to ensure that the right technology is being leveraged to be able to see the right patient at the right time.
So,
To
when you
where
say they, you're talking about CMS.
CMS, yeah,
Okay.
there is a narrative. I mean, it's led by a physician. I mean, and that's where it's interesting to have a specialty physician. I don't want to speculate or assume or speak for Dr. Oz himself, obviously, but the um, it's interesting when you have a specialty physician being at the helm of something of such broad implications and influence, to where it's not a specific, artery cut in the middle of this procedure that will then yield a better outcome for the whole body. And that's kind of where I will say they're not doing that. They're taking it where the point of unlocking bureaucratic red tape, where technology can be leveraged or utilized to where health systems are operating more efficiently than before, to where it's the right patient at the right time with the right care modality or method. And that's where to then maximize when or provide the yield the highest outcome. That's what they think. And I mean, they'll say it in a different capacity, but that's where it's also where the actions are also in that in a very positive way. um and I by no means am someone to drink the Kool-Aid, absolutely not. The actions are looking at it one way, where the point is to remove bureaucratic red tape, start to look at the broader HHS interoperability healthcare ecosystem unlock, and then repurpose some of the funds. And there is a lot of back and forth around what the ACA and the new rural healthcare transformation is actually doing. But the intent of that is to find then the right type of technologies that health systems, FQHCs, or any of these stakeholders, provider stakeholders can get receipt of, and at no cost, essentially, in this program, and reinvest, then get to that ideal outcome where they're receiving the right information, the right time, delivering the right care at the right time. And that's their MO for sure. It's to be more efficient in care delivery, if that kind of answers your question. So I think for the winners and losers of that, um, I mean, yet to be seen. I think just naturally there will be a survival of the fittest, so to speak. Those willing to lean into that will be at they will. I mean, they will be a winner. I mean, and I think that it's a massive amount of capital to be deployed. That if you do not participate, I don't think it's something that you want to be wondering what if. is kind of the vibe that I've gotten. I mean, participate, shoot your shot, get the investment in, really hone in operations, and you know, focus on core outcomes, and then that will lead to better efficiencies. But that's the hope.
Being a fast follower simply won't work.
I don't think so. I don't. Yeah, I think. I mean, it has to be a core efficiency that you are unlocking, and if it fits the narrative of a part of the broader unlock, then that will be it. I mean, I've seen videos where they're trying to do digital health wallets and they're pitching national app initiatives to productize CMS, where you could order pharmaceutical supplies directly through CMS through a CVS integration, which is crazy to think that that could actually happen. I mean, at this rate, I think anything is possible. I do know what's being tested as far as a integrations and interoperability standpoint is being centralized at Department of War and VA, and then that will crosswalk into CMS. I do know that. So
You obviously have studied it well, because you did say Department of War. I still say DoD. So
yeah.
that I've aged myself. Either that, or I'm not willing to learn the new name. I'll work on it. Couple of things. I mean, we could spend a, a bunch of time talking about any of the paths that you touched on, but there's a couple that jump. One, let's keep the theme right now with CMS,
Yeah,
and
for sure.
it seems a little out of phase with the government's stated, at least in the most recent past, stated goal to grow and enhance Medicare Advantage, and then look at the reimbursement in 2027 being relatively flat, causing organizations that accept those funds on CMS's behalf and operate Medicare Advantage plans. So the large commercial carriers, and then regionally some of the smaller carriers as well. Are those things out of phase in your mind?
I don't think they're out of phase. I think it's almost like there had to be some contraction and I should say contraction, but also pause before things can be repurposed or reinitiated. For example, I mean, for the event, say for an entity in the federal contracting community,
Mhm.
there's been essentially zero new funds initiated to CMS. It is literally to keep the lights on. And they're taking that existing budget that they initiate to contractors, which of course is just to make sure CMS is operating. Nothing to do with the healthcare side of what care actually exists at in the provider community.
Right.
And they put a pause on that entirely to where they're repurposing those funds as we speak. And so, I mean, if you have a contract, I mean, you can call any contract in the DC, DMV Beltway area. The new contract awards are almost non-existent in CMS, which is historically absolutely not the case.
Too vendors.
And yeah, new administration comes in. Tickets are hot off the press, contracts are hot off the press, and they got new. This administration got their new budget, new money, especially in a January, in a new administration, new budget. That 2026-2027 turn is technically the first year budget of this administration's impact and this leadership's impact, really. And that's the part where the 2025 pause, where the new administration came in and they just paused everything. Doge came in, seeped its claws into CMS in a good way, because a lot of this stuff is, I mean, if we want to talk about duplicative efforts, there are contracts that are just the same thing, and CMS is paying millions to just get the same benefit from multiple vendors and not actually have an outcome. So they are looking at where if that can be repurposed to provide additional grants focus. That's where, and to help answer your question, that's where we see majority of our time being in the CMMI, which is the Center for Medicare and Medicaid Innovation, which oversees the legislation and policy work around new models pertaining to Medicare Advantage populations, and how that Medicare Advantage population is going to be, uh, um, I won't say govern, but we'll say from the models will impact those populations in which providers adopt those models. But that's where the innovation also lies too, where they're coming out with models like almost every month. I mean, there's been 5 new models, I think, this year, in 2025. And that's a big deal. There's a lot. And I think they're still trying to figure out and glean, how providers can be effective, what providers need. I mean, they need some flexibility, in
Right.
how they navigate Medicare Advantage populations and how they provide care, but it has to make sense for them to receive funding, adequate funding, and appropriate funding to be able to operate, in a sustainable manner.
Let's flip to the rural transformation funds.
Yeah.
What looks like a big chunk of change, at least at the gross level, at the top line level, that 200 figure with a lot of zeros behind it seems like a lot, but when you start spreading that across the nation, maybe not
Yeah.
so much. And it's state by state. States had to opt in. They had to say, we're going to administer it in this manner, and everybody gets to, I think, do their own thing, state by state. So it sounds good. Is it going to be effective from your perspective? And what are the tripwires that states need to be aware of?
Um, I mean, that's the part where I think the states have to have, from what we've heard, we're working with about 13 different states right now, pretty heavily. And I think what we're seeing on the state side is that there's a disconnect on what the priority effort is actually. I mean, you have to realize many state health ecosystems, like the specifically pertaining like the state MMIS, the state Medicaid management information systems, which are the essentially the core repository of data in, data out, everything from provider services to claims management to
Well,
um,
that's a patchwork quilt, right?
oh yeah,
It
it's
that
yeah.
nothing matches there.
No, nothing at all. But I mean, so yeah, I had a stint as Idaho's vice chair of the HIE, and so and understanding like the TEFCA frameworks and ONC's effort and where HHS is going with that. I think the states will not be able to. My concern is that the states will not be able to adapt or initiate an appropriate plan when it comes to what the providers need if the core state central system is so antiquated and outdated and ultimately broken and patched over. And that's where I'm sensing, getting a sense that that will lead a priority where the states will do that. The provider, those are the largest contracts essentially at the state level. I mean, so to speak, are these information systems, and they're really sticky. And I think they will have the providers who the groups and technology firms who provide those services are the other ones that have a first in line to get the state to basically use funds that they were not necessarily anticipating and then get the investment that way, which then could yield a better outcome for providers potentially. When it comes to what providers or health systems can do, I think it's to lean on the goals of the administration. Started looking at adaptive and innovative solutions when it comes to patient navigation tools, care navigation and care journey mapping, transitions of care, so to speak, software implementations. Those are things where you can start to look at, again, providing the right care, building efficiencies, better continuity and rapport with patients, and ultimately, hopefully, operate more efficiently. That's what CMS wants the funds to be used for. And so I think the health systems or provider groups or FQCs or critical access who can really hone in on a core. This is what we are going to do and how it checks these boxes from a narrative standpoint and a plan to implement and a clear showcase of what those outcomes are and how they're going to be measured and governed. Those will be the winners of these grants, so to speak.
When you gaze into the crystal ball, what are the issues that healthcare leaders should be tracking today? Top three.
Financial posture is the biggest one. I think. I mean, I think even how you eloquently touched on some of the aspects of how Medicare Advantage populations. I mean, the Medicare Advantage, it seems like it's throttled down to this administration, and that's where, um, the administrator himself was, I think he sat on Humana's board for like 12 years, something like that, and the Medicare Advantage population. I mean, this is double down is what they're going to do, and that's kind of where the actions say. I think the financial posture and understanding of these different models coming out pertaining to the healthcare economics of Medicare Advantage, providing care of Medicare Advantage populations, and even the dual eligible populations are for sure the biggest. That to me is the number one. How you engage in care with that, how you optimize provider resources, how you better patient experience in those new confines of that like new equation, so to speak.
Mhm.
Um, that's the number one thing to focus on. if I were a hospital executive. As we meet with hospital executives and we consult with different innovation hospital teams. There's one in Maryland that we recently we meet with regularly, and that one it's a health system of I think 60 locations ish, and it's all urgent care ED based, and they're a full thriving health system, but they're 99% fee for service. They're not changing, and we were been kind of warning them about this for the better part of 8 months, and now they're finally. I mean, email this morning of just like, okay, you're right. We should probably look at this, and it's like, yeah. I mean, there's no more kind of skirting anymore. And how you operate in that space is going to be interesting. The other items are coming down to, um, I think, really the way care is being shifted, and how patients are seeking care, and the delay of which how they, chronic conditions can exist for 10 years. And I think we're how to use technology to define the point of origin, where patients have been potentially searching and triaging the symptom from themselves in over counter capacity.
Right.
And it's ultimately gotten worse because they have done that. The barrier to care has been high. Like, there's a deductible, there's $50, like in Google for free. I mean, there's a lot in that psyche that I think if we as healthcare leaders, um, were able to, which is also why I'm bullish about Medvale, to where we can just talk about that and almost like remove our um self from the delivery aspect and start to resonate more with the patients, where it's like we all do this, like we all symptom search the first couple times, like, hey, am I good? Or one of my best friends is a NP at a facility in Idaho, and he basically is my care concierge nurse. Like, we don't go to urgent care like that because I have him, and you send him a picture, and I think that stuff matters. And I think when we really start to honestly look at what patients seek, and do it from a way of not what we as healthcare leaders are delivering, but we ourselves as patients and how we navigate the system, I think that will have a better approach of how the industry moves forward. And that just comes from a very humble take of just being real.
Well, thank you. And we also have a longstanding tradition on Megaphone, and now it's time for insider guidance. So I know that you live in Boise, Idaho. You also frequently travel to inside the Beltway, Washington
Oh
D.C.
yeah.
So we need a twofer from you. What is the must-do activity in both places, and
Okay.
also what is a your favorite eatery in Boise, the Boise region, or
And in DC.
Idaho?
Okay.
Sounds like you travel around a bit, Idaho as well, and also Washington D.C. Because Maria and I are keeping track so that when we hit the road in the big Medvale motorhome to take this on the road. I'm kidding. I think the mayor
Of
just
course.
had heart palpitations when I said that. Um, why don't you give us some recommendations?
Okay, so I would say, for Boise, best food, best food in Boise, go to. Um, man, I consistently have, I think, the best meal, um, at a newer enough place in Idaho that is Coatahima. That to me is like that's like our go-to. That's like our family go-to.
Got it.
My daughter loves it, my wife loves it. We will default towards like more of a Hispanic Mexican cuisine, and I think that one is like they just do a stand-up job.
Great.
It's simple, it's elegant, it's beautifully done. And then and it's fairly priced, which is obviously a good thing. And adequately priced. As far as outside of Idaho, I think the if it I don't know why I haven't taken that route up to get through Haley yet, but in about 3 years. So if Blue Bunny is still around, or sorry, or Snow Bunny, sorry, if the Snow Bunny
Nobody,
is,
nobody drive-in. You know
then
it.
if Snow Bunny is still around, Snow Bunny is to me like the quintessential Americana burger joint.
Ah,
Like that's like where it's at. I grew up as a kid going to church camp in Sun Valley, so like it's like you always stop there. It's like the Snow Bunny is like that to me is like the burger of all burgers. Like
I
slider
bet there's
tots, yeah.
I bet there's a burger on the house waiting for you after that recommendation. What about Washington D.C.?
So Washington D.C., there's a beautiful locals I think there's not very many of them, maybe about 5 or 6, but they're local, like cafe bakeries, called Noms and Namans, Namans.
Okay.
Um, and they are excellent. They have their coffee is delicious. Their food and their pastry selection is just, it's like out of a movie. I mean, it is
Wow.
straight. Yeah, you walk in, it's like you almost don't even want to, you're intimidated to order because you're looking through the glass and it's just this like beautiful display of pastry perfection. And it's just this, it's like, where do you even begin to choose from? And they have, I mean, curated plates as well with steak and eggs, like they do like very avocado toast with poached egg on top. Like they I mean, it's breakfast and it's lunch and it is absolutely to the nines, and everything is just beautifully put together. The best thing I've had there for sure is the croissant, the 1,000 layer croissant layer cake, and it is a flattened croissant. It's not 1,000 layers obviously, but it looks like it, and it is a very it is a croissant layer that's just this and it has this perfect meringue brulee meringue on top. It's like
Oh,
come on.
fantastic. Okay,
Yeah,
now I'm actually hungry at this juncture, and I'm not in Washington D.C. I'm gonna have to figure this one out. Um, our producer director Maria is taking notes. So again,
perfect. Yeah.
when we have the travel and roadshow for Megaphone, we know where we're headed. Kevin, thank you very much. You get the last word today. What message will you leave us with?
I mean, I don't have all the answers, but I'm willing to roll up the sleeves and help my fellow healthcare professionals figure it out. So, I mean, there's more work to be done for sure, and let's roll up the sleeves and get it done.
Right on. Well, we look forward to seeing you at Medvale Summer Camp in June
Definitely,
in Sun Valley. I'm betting that on the way into town, you stop at Snow Bunny. It
it's gonna
sounds like
happen.
that's going to be
Yep,
a go-to for you
absolutely.
in Medvale
Yeah,
Summer
it'll happen.
Camp. We'll
Usually
visit
I've
again
been
when
taking
we're
the other route, but I've been taking the other like through Stanley route. So it's funny, like I come in the north side now, so it's like it's just yeah, you gotta go up through Haley though and get that burger.
Well, thank you so much, Kevin. That's all for this edition. But join us next time for Megaphone from Medvale Media. I'm Dave Self. Be well.